All right, wonderful. I'm Dr. Glenn Clark, and I have the pleasure today of interviewing Dr. Parish Sedghizadeh. And we're going to talk for a few minutes about leukoplakia and its various forms of presentation, unless Parish goes in another direction, which is fine. And let me start by asking a couple of questions. Parish, you gave a presentation to the alumni recently, and you were covering cases that they might commonly see that are problematic. Was leukoplakia one of the diseases you covered, and why did you choose it if you did?
Yes, I did. Leukoplakia is one of it. As long as we've had this term leukoplakia, I feel like it's still a confusing and challenging term for clinicians to understand. It basically means white plaque, but then there's different specialists and pathologists that say, no, it's only reserved for white plaques that are dysplastic by biopsy, by definition. And others teach just call anything a leukoplakia until you figure out what it is and biopsy it. So it can be keratosis, it can be precancerous. Seeing, obviously we get a lot of referrals, to our USC clinic from clinicians outside. And it's one of the areas where I think is just very, very challenging for people to understand what leukoplakia is and what are precancerous conditions and the different forms that leukoplakia takes, like proliferative verrucous leukoplakia versus like a conventional leukoplakia and things like that.
Now, as a generalist, do we have an echo? No, I don't. I think we're okay. We do have an echo. No? All right. As a generalist, leukoplakia is a valuable concept,
Yes.
to teach the dental students and the dentists out there in the world that aren't specialists, because it allows us to name something, and we know that it's not the final diagnosis, but it's got potential danger, there, and not all leukoplakias need to have a piece cut out and sent to the lab. So what do you tell the generalists to do? How do you get them to say, well, this one you can just watch, it's keratosis, you're just chewing your tongue. And this one is very dangerous, you must break it down into several categories. What do you do? What do you teach?
Yeah, this is a very challenging area because, like I said, there's so much confusion here, and you don't know different people's skill level clinically. And so, early on it was, I think I was really inclined to say, okay, if a leukoplakia is a white plaque and if it's on the tongue and they're chewing it, then you can watch it and fix the tooth and smoothen it a little and make them a night guard, for example, and then it should resolve and go away. I still think that's a good idea, but for a short amount of time, like 2 weeks or less generally, because especially on the tongue, since we're talking about this, one of the most high-risk sites for dysplastic and cancerous lesions is the lateral border of the tongue.
Yeah.
So it's also a site that you might nibble on or chew on, or might hit a tooth or scrape on something chronically and have like some keratosis or a white plaque. So I think more and more I've realized that if you don't know what it is, it's biopsy is the gold standard. You can wait a couple of weeks and then that's it. You really can't wait much longer, because unfortunately I even see like malpractice suits because a clinician watched a leukoplakia on the lateral border of the tongue for like a month, and you're like, oh, well, that's not bad. And then they finally said, no, you should go get this checked out. But even that was interpreted as being a delay in diagnosis, and then the patient's cancer was more advanced, and did that 2 weeks make a difference? Who knows? So it's things like that where, I just say, especially high-risk sites like the tongue. Now, if it's like bilateral buccal mucosa, right at the linea alba,
your cheek.
Yeah, you can see that they're chewing it while they're sitting there, and it's bilateral. Then maybe you can watch that. But I've seen dysplasia of the buccal mucosa, cancers of the buccal mucosa. So it's just without histology, you just don't know, right?
Yeah.
You're guessing. You're guessing.
Now, I know that a few years ago we were approached by manufacturers of the transillumination, or not transillumination, but illuminating devices that you could look through the scope and see whether it was dysplasia or not dysplasia. And we looked at the device, but we basically didn't ever use it, and we sent it back. We said we don't trust it. You know, I mean, other people might use it, great, but I know in our clinic we said no, we're not going to use those devices.
Yeah.
Is there a role for them in general dentistry?
In general practice, you know, for dentists and hygienists, I think there can be, because, you know, as an adjunct to diagnosis, they can be useful. You know, as a routine, some dentists or hygienists will routinely use these, and then if they see anything abnormal, then they'll make a referral or recommend a biopsy and things like that. If you're doing it for that purpose as an adjunct, it's great. Personally, as a specialist, I don't use it much because I need the gold standard. I need the biopsy. I can't delay it another week or two and, you know, see if the brush shows this or the light shows that. It's basically based on clinical suspicion. The problem is a lot of these modalities don't have really high sensitivity and specificity, or if they have high, you know, if they have sensitivity, they don't have high specificity.
Yeah.
So you don't know what you're dealing with until you have the kind of the gold standard histologic diagnosis.
Now, when you have one small area, you know, and you take a piece of it, you're probably in the right spot.
Yeah.
But when it's a big area or it's multiple areas, what do you tell people on how to decide where to cut? Because that piece should represent the entire sample. And how often does it, and how often does it not?
Yeah, it doesn't always, you know, and that's so. Again, it's how well trained and confident and experienced is the clinician to know that one sample they're taking is really representative. Personally, I feel comfortable when I take one or maybe two tops, if there's different areas. Maybe one's more erythroplakic and one's more leukoplakic, for example. I might take a couple of samples. ENT will take multiple samples routinely for incisional biopsies of these types of lesions, one in each area in the center and the sides and things like that. But, you know, one nice big enough sample should also be pretty representative depending on the size of the lesion. It's all really the individual clinician's kind of comfort. But that's why sometimes pathologists will make comments like, you know, there's severe dysplasia in the specimen, you know, or moderate to severe dysplasia. But some areas are worrisome, and since this is an incisional biopsy, or stated to be an incisional biopsy of a larger lesion, this may not be entirely representative of the pathology.
Yeah.
There may be cancer like 2 millimeters away from where you sampled that you didn't sample, and you might get a false sense that, oh, it's only dysplastic, there's time, you know, or I don't need to refer this out, etc.
Now, if I had a moderate-sized leukoplakia in my tissues of my mouth, and it was sampled, a little piece was taken out, and it was negative, I wouldn't, knowing what I know, I would not be relieved. I would still have a worry that would still, you know, hit me in my brain at 2 a.m. when I wake up. And so
that's great. You would be a great patient. You know, I know you think you would be not a great patient, but as a pathologist, I would love that, because I know you're going to come to me with anything, and that means we're going to catch something. You know, obviously, if you're not being neurotic and like somatically focused and things like that, but yeah, that's normal. That's absolutely normal. Like, well, okay, the biopsy said it's clear, but you know, and a lot of people, we see this, right? They come to you and they say, oh, I had a biopsy years ago and it was negative.
Yeah.
Or I had a biopsy and they said it was benign. I don't know what that means. As a pathologist, I've never diagnosed something as negative or benign. You know, there's a diagnosis. You know, like it might be like keratosis. You know, frictional in etiology, clinical correlation recommended, or verrucous keratosis, or mild dysplasia with features of, or, you know, like there's always a real diagnosis, not negative or benign.
Yeah.
So, but I know that's a lot of times that's what the patients are told, or what they remember, or the way clinicians like to say, oh, don't worry, it's fine, it's benign, for any diagnosis that's not cancer, you know, versus explaining, oh, this was a granular cell tumor with, you know, like, they might just say, it was benign, don't worry. But yeah, you'd be a good patient actually, because then we would see anything that kind of pops up or doesn't resolve, and we would follow up. And there's a lot of times something is totally normal. You do another biopsy 6 months later, the patient's like, oh, it's still not going away. And then all of a sudden it's dysplastic. Yeah. You might not have had the right sample, the right area.
Or it changed.
Yeah.
Now, Parish, obviously when you see a change in the tissue and you've ruled out scars and trauma from cheek chewing, you're worried about it. And the appearance of the tissue sort of dictates your follow-up plan. Now, we're, as a generalist, we're taught about homogeneous and non-homogeneous and red and white areas of the lesion and then the verrucous form. What's your follow-up plan? Is it different for those conditions, or is it always the same? I see you every 3 months for the rest of your life. What's your follow-up plan?
Yeah, no, I mean, so initially, when I get any kind of white leukoplakia, if you will, and the biopsy shows, there's different things that can come back. It can just come back keratosis. It can come back verrucous, hyperkeratosis, which means it's a little more rough and bumpy and maybe coming something worse eventually, right? But we don't know, so we can only just call it what we see. And then there's some that sometimes have interface inflammation, like there may be some verrucous hyperkeratosis with like almost a lichenoid infiltrate, and then it's like, well, let's say it's on the gingiva, then the clinician is confused. Is that lichen planus? Is it lichenoid mucositis? Or like, is it a crown in the area or a filling, or, or is this like dysplastic? Is it precancerous? And so there's a lot of these different histologic diagnoses that come back, like lichenoid mucositis with epithelial atypia. Some use the term lichenoid dysplasia, although I don't really like that term, but you'll see all these different, uses. But the key is really, you have to let that histology guide you along with your clinical, is it getting worse, progressing, maybe it's changing, maybe it's different, and then determine how to it's really an individualized approach to follow up. But there's general rules, like every 6 months or every year, re-biopsy it. So let's say you do a biopsy and it's mild dysplasia with some inflammation, and the pathologist says, I can't tell if the dysplasia is reactive because there's so much inflammation, or if it's truly a precancerous process. Clinical correlation and follow-up is recommended with periodic biopsy. So we'll generally say, if that lesion is still there and it doesn't look bad, but it's still there or getting a little worse or whatever, then re-biopsy every year to reestablish the histologic kind of status. I've done patients where every 3 to 6 months I'll see them initially, maybe biopsy every 6 months initially, and then after a couple of years I realized, okay, this hasn't changed at all, and the biopsy always comes back mild dysplasia, so, let's go another year this time, versus
this can be a sliding scale then. You can
and I've
initially height.
Yeah. I've done cases where it's like, 2-3 years have gone by. The lesion is still there. I've lasered it, it's come back. It's still dysplastic. But then, 3 years later, I do another biopsy, and again, it's still like mild dysplasia. But I waited 3 years because it just wasn't changing, and I was comfortable enough having seen it month after month, year after year. So, yeah.
The worry, of course, is that the patient doesn't follow up with your recommendations.
Yeah.
And you don't have good documentation that it was absolutely essential for you to come back and let me check you every 6 months or every 3 months or whatever you decide. How do you write your note so that, in case somebody forgets that you told them this and they blame you now, how do you write your note to get it right?
Yeah, I it's always very explicit and succinct in the plan. Like let's say we do our SOAP note, in the P part of the plan. I always say, patient, we discussed all the findings, all the patient's questions were answered, and then we specifically discussed that for this lesion, generally long-term follow-up is recommended with re-biopsy is clinically indicated, and the patient kind of understood, nodded their head. It's a couple of sentences just. And I this is real. I mean, this is what I do with the patient. I just say, this is something where, and I get a sense right away, like, do you understand? Do you know that this is something, and I get a sense that, yeah, I get it. I'm going to come see you every 6 months, versus like, kind of, I don't understand what's going on, or,
Yeah.
So it's one of those things. And then I'm very, very careful with these patients. You put them in like a separate book, for follow-up book, like you said. That's really helpful because these are the patients, those white plaques under the tongue, on the side of the tongue you weren't worried about. And then suddenly it becomes a cancer, and you're like, oh, geez, what happened, right? And it's not going to go away. Somebody's going to biopsy it and diagnose it. So those are where those notes have to be really, very explicit, that you discussed this, the patient understood. And then if they, in 3 or 6 months, they don't show up for that recall appointment, I make that appointment for them right away, right? Don't say, oh, we'll call us and come back in 6 months. I don't like that for these types of cases. I say, okay, let's schedule the appointment right now. And then you can change it if you want, but at least it's on the books. You have it, you know that you need to be coming back to see me.
Yeah.
And then if they don't show up or change it, I make a quick comment like, patient didn't show up. This is a leukoplakia case of, potential dysplasia or cancer. Eventually need to have follow-up, call patient, etc. You got to have your staff and follow up with those patients.
Parish, I had a little lesion on my face, and I was seeing a dermatologist, and he said, don't worry about it. And I said, but, suppose this was a early form of dysplasia. And I wanted to, and you biopsied it, and it was positive, and I wanted to make it go away by treating it with a chemical that would make it go away. He said, don't bother. He says, the evidence suggests that you can indeed suppress it, but as soon as you stop using retin A or whatever your favorite chemical is, it comes right back. And it also gives the patient a sense of false security, that they're managing it. So that was skin. What's the issue with mouth? You have multiple leukoplakias, and they're worrisome. They're not cancer yet.
So on your skin, what was the diagnosis histologically?
Oh, he didn't do it because he said that's just a sunspot. Don't worry.
Okay, so it differs. So on the way I approach the skin is very similar to how I approach the lower lip. So like actinic cheilitis, for example, sun-induced, by definition, that's the same as actinic keratosis, right? We call it actinic cheilitis. In that location, since you're giving that derm example, that's a very specific, by definition, actinic keratosis to dermatologists is a dysplastic condition. It is by definition a precancerous condition. So we don't, on their report, they don't put like actinic keratosis with mild epithelial dysplasia like we do in the mouth. It's just they put actinic keratosis, and it's known that means there's dysplasia, and it's a precancerous condition. In those cases, then it behooves the dermatologist to then treat that with chemotherapeutic agents, which are the standard of care. You can use laser, cryo, surgical removal, but the real common and standard of care, especially you get a bunch of these all over your skin, lower lip, is to use chemical like 5-FU or imiquimod.
Burn it off.
Imiquimod's the big one. And those work. The evidence isn't no, those don't work, and it doesn't matter that it's giving you a false sense of hope. That's actually treating a dysplastic condition and preventing cancer formation or prolonging it. Yeah. But it's a different story once you go in the mouth, right? On the lips, some clinicians aren't comfortable using those chemicals because they're not meant for ingestion. They're not FDA approved for mucosa. They're approved for skin. You can do it, but it's tricky. As a clinician, you have to know how to tell the patient, like, I don't want you ingesting this, but there's a whole kind of thing. So if you're not comfortable with that, then for the lower lip, the surgeons can do vermilionectomy or lip shave, or laser, things like that. Or if you use SPF 50, and year-round daily, you can actually regress these lesions because they're sun-induced. Yeah. Once you get into the mouth, it's a whole different thing because most of those are either no known risk factors or smoking and alcohol or HPV, right? So depending on where it is and what it is, then those are some of the things you need to address, right? You need to address, the risk factors, prevention, all that kind of stuff. And then the treatment, we don't have chemicals you can put on in the mouth.
Yeah.
So we can't go to that discussion. So it really has to be either you watch and wait and keep rebiopsying until it gets worse, or and then or remove it surgically. Yeah. Exactly. There's not much choice. Laser, cryo, things like that. No, but the evidence is still not definitive on those.
If I walked into a nutrition store and I said I want an antioxidant, they'd give me green tea and a few other products. Well, is that false hope? that those
Yeah,
would
no, I mean, there have been clinical trials. There's some really prominent investigators that have done in head and neck cancer and looking at, like Susan Mallory is a PhD at Ohio State University. She's done some really interesting work looking at antioxidants topical, like black raspberry and things like that. But in general, we know that, especially if you think about the cancers that are produced by like smoking, combustion products, that's an oxidation-rich environment. So if you can quench those oxidants with antioxidants, either topical use, which there's no real product yet, but these things are being developed, or just lifestyle, right? Exercise and diet and eating more fruits and vegetables, which have more antioxidants in them. You can quench some of those free radicals technically and then slow down or prevent the cancer formation with, of course, quitting the smoking. You got,
But
the risk factors.
let's go back to my dermatologist, and he said they do suppress, but when you stop, it comes right back, and therefore we don't recommend them. Now, that was one person's opinion.
Yeah. We don't have that kind of data for the mouth, though. For the skin, he understands that body of evidence. We haven't done those studies really in the mouth where we have enough evidence to be able to say what antioxidants and those kind of topical chemotherapeutic agents or pharmacotherapeutic agents, we don't have robust, we have nothing of retin-A in the mouth or, like all that kind of stuff. So.
Now, when we see dysplasia, it can be mild or moderate or severe or carcinoma in situ. We want to remove it if we can, but sometimes it's so widespread that you can't. But when do you go in and burn it off? And is lasering it off, if it's potentially HPV induced, a safe process?
Yeah, good question. So most of those HPV lesions are oropharynx, like base of tongue and posterior into the throat. So we don't really laser that far back, and they don't often have like a leukoplakic precursor component, just suddenly you see like a fixed node or, it's a different beast, the HPV lesions in general. But those ventrolateral tongue lesions, you're right, they can be very diffuse. A whole half of, somebody's ventrolateral tongue, even creeping up towards the dorsal and going, and that's a lot to strip all that, right? Yeah. That's a big procedure for something that's not cancerous and may not become cancerous. So these are honestly the trickiest ones. You have a dysplasia, maybe it's slowly progressing over years. It's at a high-risk site. What can you do now? It went from mild to moderate. You see it getting wider and thicker, and you're just like, oh, no. And there's no risk factors. They're otherwise healthy. And these are the most challenging. I do laser these. In our clinic, we have a laser. We use it. And there's different philosophies and what type of laser to even use, CO2 versus diode versus, some of these.
Now, I went to a conference a few years ago, and I listened to this surgeon who diagnosed dysplastic lesions and then surgically removed them. And then he had a group of people who didn't get surgical removal. And he looked at this is an older guy, so he had 30 years of experience. And he said, the number of people that got cancer of the mouth when I didn't remove it versus those where I did remove it were about the same. Mm-hmm. But I still remove it because there's a chance that it might capture it and get it. Because once you get... So what's your opinion about that? Is it worth it?
And that's the tricky part, right? I mean, I think a lot of surgeons will remove it because it's, as a specialist, it's referred to you, it's dysplasia, it's been biopsied, you did the biopsy or you confirm it, it's not going away. And then, the patients are going to say, can you remove this? Or can you take, this is precancerous, I don't like what you're telling me, so what do we do, And surgery is still one of the main modalities, technically putting a orientation suture in, taking a margin of clear tissue clinically and seeing if it's histologically free of margins. I mean, it's done routinely, daily by oral surgeons in our oral, pathology kind of, dental setting. But it's tricky. Yeah, the evidence is not good either way and like with laser too, at a high level, controlled randomized don't really show that there may be much difference. But I think a lot of people are just comfortable with that, right? I don't want this in my mouth, so if you can get it out, get it out. But we also know there can be a field effect, right? Even what you remove normally and even histologically, I still have to follow that patient lifelong because, let's say I'm the surgeon and I do it and I remove it and they say, oh, margins are clear, no dysplasia at the margins. This is still the ventrolateral tongue. It's a high-risk site. This patient may develop a lesion 3 millimeters away from where I took something, right? Because there's a field effect. What looks histologically normal, there still may be genetic alterations and those may become affected down the line. We know for these upper aerodigestive precancerous and cancerous lesions, patients are predisposed to having more than one over their lifetime. So let's say you get the one in the mouth, they can develop one in the throat or down in the lungs, right? If the smoking was a risk factor, for example, that entire anatomy is at risk. So it gets really tricky with these lesions. I've had stuff where I laser it, comes right back a few months later, and then laser it, but maybe the patient feels good about it. I feel good about it. I'm doing something versus nothing. Or sometimes I'll cut it out to get histology again and margins and things like that. But it's tough. It's one of the toughest areas we deal with, I think.
When you see a lesion that's right at the edge of turning into a dangerous cancer, sometimes you send the patient off to the oncologist.
Yep.
And sometimes you treat them yourself. How do you make that decision? Is it you want to get their attention and shake them up a little bit by saying you're going to the cancer clinic, or is it that they're going to be more aggressive and cut more tissue out, and that's not in our skill set, or we don't do that type of surgery?
Yeah.
So what's your decision process?
Yeah. It is they're with if I get things like moderate to severe dysplasia or carcinoma in situ. Then I get worried because then I'm like, okay, what about other areas I didn't sample, or if this is big enough? At that point, sometimes I'll say, okay, do a wider excision, but that's a big procedure. Even a 1 to 2 centimeter wedge out of the tongue is a big deal. The patient's going to be in a lot of pain. It's a big procedure. It might need some deep sutures, things like that. So then that's when we usually will call upon our ENT, head and neck oncology colleagues. To manage it. They don't like to manage the mild to moderate dysplasia.
Exactly.
Just send it. I don't even know if that's really dysplasia because a general pathologist would say that's normal tissue, But once it's kind of severe dysplasia to carcinoma in situ and it's a bigger lesion, maybe more rough and bumpy, I think they get that these are kind of high risk for cancer and they may do more aggressive surgery on some of those and actually just excise it, at laterally and deep, margins to be really clear. I think once I get to the patient where I'm just kind of like, I don't think this is going to reverse. I don't think you have a dysplasia that's going to get better or go away. That's when we, get the head and neck ENT guys on board.
Yeah, and when they refuse to stop smoking too. A wonderful interview, Parish. Thank you for the great answers. I have to do a slight commercial.
Yeah.
For all those dentists out there that are hygienists, anybody in the professional field that are interested, we obviously have online programs for the practicing dentists, practicing hygienists. And the programs are various types. They're all for the working professional. They're a full year program up to 3 years for a master's degree. So if you're interested in advancing your knowledge and coming up to the highest level possible without quitting your life and stopping your income, look at our website, ostroon.usc.edu. We have 9 or 10 different programs, and hopefully we could help you if you want that kind of educational training. So, and Parish, wonderful job. Parish runs the oral pathology and radiology 1-year certificate program, and mostly it's general dentists out there that are upping their game, and that's what we are trying to do. So that's where we are. I think we're out of time though, so I could go on with you forever.
I know we could talk forever. This is what we do in rounds.
Yeah. So we'll have to stop here. David, do you want to take over?